Welcome to Talks with Docs. My name is Dr. Lisa Peterson, and today's topic will be on common childhood rashes. We had a request from a viewer wanting to know more about hand, foot, and mouth disease, and so we decided to talk about that as well as other common childhood rashes. So today, our guest speaker is Dr. Stacie Bleicher, who is a local pediatrician. Welcome, Dr. Bleicher.
Thank you, Lisa.
So we'll start out right off with hand, foot, and mouth disease. We've recently had an outbreak in Lincoln, and so what can you tell us about it and what parents need to be concerned about?
Well, I think first of all, I want to reassure parents, some people think this is the same disease that affects livestock, and it is not. This is strictly a human reservoir disease, and it actually can be caused by a fairly large group of viruses. The big group that contains them is called enterovirus and then Coxsackie virus, but there are multiple strains that can cause these symptoms. It used to be we only saw this illness in late summer and fall, but it seems in the last 5 to 10 years that we see it in all seasons, perhaps because children are in daycare and have a more extensive reservoir where they can share it all the time. But we see outbreaks at many different times of year now. And there are a few symptoms that are very highly associated with this type of infection, especially the first time a child gets it. It is a virus that tends to cause very high fevers. And
when you say high fevers, how high?
102, 103, okay. Sometimes 104 in the evenings.
Okay.
And the fevers themselves are not harmful to the children. The children that are over 2 feel absolutely miserable with them. But it's part of how their body responds to and fights the virus. But in addition to that, many of the strains will have ulcers or blisters on the roof of the mouth or on the tonsils, so the children have very sore throats. They don't drink very well, and it's mandatory that we get fluids into them to control their fevers. So that's a little bit of a struggle for families to deal with. The strains we've seen this spring and summer have been a little odd because we've seen more of the skin manifestations of it. The most traditional findings we'll see are very small blisters on the palms and the soles of the feet, but we've also been seeing a lot of little red or pink bumps on the arms, legs, in diaper areas, and in non-traditional places this year. So we've had a lot of rash and less fever with the strain that's been here.
How does it start? Does it start with the rash or does it start with the fever?
It usually starts with the fever,
okay.
Although we had some this spring where they were mostly rashes without significant fever.
So when does the parent call the doctor then? What fever do you tell them, 103, 101? Or?
We're not going to deal with 103 fever except to control the symptoms urgently during the night, but those are frightening fevers, and so frequently we do speak with parents in the late evening when the fevers tend to run the highest to give them guidelines for, be sure they're using appropriate doses of acetaminophen or ibuprofen if the child's old enough, and information about getting lots of cool fluids on board and dressing them lightly, those sorts of things, especially our younger infants. If we bundle them up because we feel like bundling as adults when we have fevers, we perpetuate their fevers. So we want them lightly dressed to get the temperatures down a little bit better. The biggest thing that would bring them into the office is if they're not drinking enough to be having appropriate numbers of wet diapers or going to the bathroom often enough. And the other reason we frequently see them is because daycare requires it for them to receive permission to return to daycare. Mm-hmm. It is a virus that's transmitted through saliva and through stools. With infants in diapers, it's important to use very good hand washing with diaper changes, not having children sharing drinking utensils, those sorts of things, to minimize the spread. No daycares want them when they're febrile and usually want them at least 24 hours fever-free. The illness can last 7 to 10 days, the rash especially for that period of time, but the rash itself is not contagious. Okay. So in general, I feel once their fever is down and they're eating fairly normally and can deal with being around other kids, that it should be fine for them to return to daycare.
Okay, because they're actually infectious with the rash. Or not, I mean with the fever more so than the rash.
That's correct.
Although daycares, schools, they tend to get worried about the rash.
That's correct.
Yeah, okay,
Yeah.
okay.
And it's not entirely clear how long they shed the virus in the stools. So some of the recommendations about when they go back are going to depend some on the age of the child. You know, are they toileting independently? If they're having diarrhea, problems like that, then it will have to be somewhat individualized.
Are there any major complications that parents need to be concerned about?
You know, the biggest concerns are generally with a mother that catches it for the first time during the late phases of pregnancy. If the fetus acquires this infection either just before or just after delivery, it can be life-threatening because they can get heart muscle involvement, they can get brain involvement, and there's not a lot we can do preventatively, but if a mother is pregnant and has been exposed, that she needs to just be sure her obstetrician or her care provider knows that.
Okay. And just so moms out there know, most adults have probably already been exposed to it.
That's correct. It's
So
very
that's
unusual not
hopefully
to have
not
had it.
a problem, but
Yeah.
let your OB doctor know if that is a concern though, so,
That's correct.
okay.
Yeah. And the other thing is, because there are many different strains that cause it, children can get one strain after another. Just because you've had it once doesn't mean you won't get it again.
Okay. Okay. And then the next one would be Fift's disease. That's been another concern. A lot of people might recognize that one by the slapped face look with Fift's disease. But
That's
what can
right.
you tell us about that
Yeah,
one?
and Fifth disease is called that because it is actually the fifth rashy disease that was diagnosed as a standard childhood disease.
Okay.
By the time the child has, quote, the slapped cheeks, they actually aren't contagious any longer, and it's very difficult to convince schools and daycares that that's the case. But this is a viral infection. It's a parvovirus. Some of the children will have had some mild cold symptoms, sore throat, maybe a little fever 7 to 10 days before the rash. Then they show up with these bright red cheeks that do literally look like they've been slapped. And then usually in the next 24 hours start to break out in a very lacy rash on their trunk and then their arms and their legs. The rash can take quite a while to go away. They all look worse when they're warm. So after baths or when they wake up in the morning, they always look worse. It doesn't mean they're sicker. It's just a reaction that has to run its course and be done with. This is a virus, again, that it's a concern if an unexposed woman is exposed in pregnancy, but unfortunately we never know we're being exposed when the kids are contagious because they basically have few, if any, symptoms. So, you know you've been exposed if then a child you've been around a lot has the rash symptoms, but at the rash stage they're not contagious at all.
But that they have fever with it too?
They don't always.
Okay,
Yeah.
okay.
And definitely not while they have the rash. They might with the mild viral type symptoms ahead
So you
of time.
really don't know until they get the slap face look.
Right.
If
And
they
then
get
they've
that.
already exposed everybody
Okay.
and there's not much to be done.
Okay.
And most people, again, get that once and they never have it again. So
Is there any complications besides pregnant women and children?
there are
that-
some problems with those rare individuals that have sickle cell disease,
Okay.
and some of the abnormal blood types can have some crisis problems because of the virus. But again, it's fairly rare.
Okay. So again, if daycare is holding you out of school, you're probably not infectious by the time you have the
That's
red
right.
cheeks.
That's right.
Okay.
And we've talked with the school nurses that they feel and are correct that they are not diagnosticians. They're pretty accurate at identifying what it is, but they want a physician to confirm that that is indeed what it is so that we give the okay for the child to go back to school while they still have the rash.
Okay. Okay. And then another common childhood rash is roseola.
That's right. And roseola doesn't have probably as much of a summer tendency. It seems like we see it a little more in the winter time. But it is a more symptomatic viral illness. Most kids, again, get it only once. It's caused by a virus called the human herpes virus 6, and it is not the family of viruses that causes cold sores or herpes simplex type of things. It's a whole different family. But generally, the children will run fairly high fevers, as high as 103, 104, for anywhere from 3 to 7 days in rare cases. It's fairly unusual to go that long. They frequently have very few other symptoms except the high temperatures. And when the fever breaks and totally disappears, generally within about 24 hours, they break out in a rash. And it's a pink, bumpy, all over sort of rash. It can start mostly on the trunk and then kind of spreads out. It can be on the face, on the arms and legs, and doesn't generally cause a lot of symptoms. Some of the children will have a little itching with it. Sometimes an oral antihistamine will make it look less angry and would take care of itching, but there's no real specific treatment for it. And it can last for hours or it can last for days as far as the rash goes. But again, once the fever's resolved, they're probably not a contagion risk to anybody else. There are a few cases where people think they've gotten roseola a second time, and they feel that it's probably a cousin of the same virus, that it's the human herpes virus number 7 instead of number 6 that can cause a similar illness.
And do pregnant women need to worry about
No,
roseola
I'm not aware of
at
any
all?
problems with
Okay.
that at all.
Okay.
And the only, probably the major quote, complication we see with it is fevers that go on to very high levels and come on quickly will sometimes cause fever-related seizures in young children. And if they have that predisposition, this is one of the viruses that can let us see that they have that tendency. It doesn't by itself cause seizures, it's just the high fever.
Okay. So basically, they're all kind of treated the same as far as your fluids, your Tylenol or ibuprofen. No aspirin.
Correct.
You want to
No
talk a little bit
aspirin.
about aspirin in
Yeah.
children?
And aspirin has not felt to be safe for children in a very long time because of its association with really severe complications, a syndrome called Rise syndrome that can affect the brain and the liver and be very damaging and life-threatening. It was especially associated with the use of aspirin with influenza or with chickenpox, but as things currently stand, it's generally recommended that even into young adulthood, we don't use aspirin. You use ibuprofen if you want the anti-inflammatory type of fever reliever.
Okay, good. All 3 of those were viruses.
That's right.
We don't have vaccines for them.
That's correct.
With it. So then the next rash I want to talk about would be a bacterial rash, Impetigo,
Okay.
which is also very common in childhood.
Yes, and impetigo is very common in the summer months. We do see a lot of it. Our skin is this great barrier for protecting us from bacteria. It's also colonized or coated with a lot of bacteria, but anything that breaks that protective surface, and it might be a scrape or a splinter or a bee sting or an insect bite, gives potential for that bacteria to penetrate the skin and cause infection instead of just coexisting with us. And impetigo is such an infection. Generally, it's from a strep or staph strain of bacteria, but the ones that normally reside on the skin. But if they get into the undersurface of the skin, can cause a infection that generally stays fairly localized. It will start out as a red bump, might develop a head or a blister, then they frequently either spread outwardly or you get new bumps around, or if the kids scratch other places, they get new spots. They're fairly classical looking once they get to the pustular blister stage because they get these yellow crusts on them and red edges. And very, very common, and there's not really any age restriction on this. It's one of those things you can get again and again if you tend to damage your skin a lot and you don't get it cleaned up well.
Yeah.
And so the most important thing is good cleansing after injuries, making sure kids are bathing regularly. If you do find a bug bite or a scratch or something that's starting to look red, washing with an antibacterial soap, using a little bit of topical antibiotic isn't a bad thing to do a couple times a day and watch it. If it seems like it's getting redder, it's spreading, new spots are occurring, then you may want to talk with your physician. There are other stronger prescription strength topical antibiotics, or sometimes we need oral antibiotics to clear the infections.
And this is one that is infectious too, though. You
That's
can
correct.
pass it on to other kids. Or
They need
people,
direct
so-
contact with the lesions. So if a child is involved with sports or involved with other kids and it's underclothing, or we can bandage and cover it when they're being treated, I don't usually worry about that so much.
Okay. And is that something you can also get, like say you're doing yoga on a mat at the gym or something like that? Do you have to worry about
I think you'd need actually, if you were just on a surface like that immediately after somebody that had infection, you might be at some risk. You almost need more direct contact with it. Some of the viruses very readily spread off of mats, though.
That way. Okay.
And actually, that non-impetigo, but MRSA can spread on surfaces like that a little more readily.
Okay. So if you think it's just plain impetigo, you can just treat it yourself at home, keeping it clean and dry. You don't have to use antibiotic ointments or antibiotics.
Usually, if you do think it's crusted and it's red and infected, I would use the antibiotic ointment, but you can use an over-the-counter to start with.
Okay. But if it's getting bad, it's not getting, it's spreading, then you probably need to go in and see your physician.
Or at least call.
Right. Or at least call. True. True. And that kind of, you mentioned a little bit about methicillin-resistant staph, or when would you worry that maybe that's what you're dealing with versus the impetigo?
And that is an infection we see more and more. It does peak in the summer months. And that's MRSA is methicillin-resistant staph infection, Staph aureus. The type of infection that's community acquired, we still treat very successfully with oral antibiotics, but the lesions have to be drained, and this is where they're different than impetigo. Impetigo is superficial on the surface of the skin. With the MRSA infections, the skin may look very red, but it feels like there's a big knot underneath it. They can be quite tender. Some of them will form heads on their own, and some of them will drain spontaneously if you do warm soaks on them. But in general, they really are very extensive in the deep tissues, and we need help with a physician actually opening up the lesion, making sure it drains adequately, because the antibiotics will not work if we have a pus pocket that hasn't been drained.
Okay, good. So that definitely does need treatment. So if there's a question, then just
it's better to get it
call
looked
or
at.
get in. And okay. Are there any other rashes that you'd want to talk about?
Well, I think common ones that come up, one thing we see a lot in the summer when the kids are running around at the pools barefooted and in locker rooms at pools is athlete's foot. Okay. And that is part of a whole group of fungal skin infections that are really quite common. The athlete's foot comes from contaminated surfaces in gyms and pools and that type of thing. We try to get the kids to wear flip-flops in the locker rooms instead of going barefooted. Our athletes that have hot, sweaty feet, when they're done with workouts and practices, I tell them, go home, take off those wet socks, get out of your wet shoes, get into sandals, or put on a dry pair of socks. And that's good, helpful in terms of prevention. The way it presents usually is redness, cracking, peeling in the folds between or on the underside of the toes. It doesn't usually occur on flat surfaces on the feet as much as in folds where the skin stays wet. And the best treatments probably, I prefer to use either creams. You can use the antifungal powders, and these are all over the counter. But you have to make sure they get where the inflamed skin is. So I think sometimes it's easier to get a cream where you need it. But you do have to treat at least twice a day, work on keeping the skin dry. And people give up too fast. It actually can take 4 to 6 weeks to get an infection like that cleared up, sometimes longer if it's really extensive.
And is that a reason why you should wear socks? I mean, you see kids wearing tennis shoes without socks. Does that make it worse?
It probably grows in those tennis shoes and is harder to clear it out of there than having a wet sock that you can change and get back into your shoes. So, yeah, I think there would be some issues, and I would even worry about if they've had impetigo in those shoes, that they could get reinfected from the shoe surface.
Or should they change their socks more frequently if they're out? They've been playing for 2 hours, and does that help any keeping the socks dry?
It depends on whether they've been prone to developing it, or some of the kids with certain forms of eczema, they're better off to, as soon as their socks get saturated, to change them.
Okay.
Now, the other thing we see a lot is ringworm, and it is not caused by worms, it's fungal also. And that can be just about anywhere on the body. It can start as a small, scaly, circular patch. Usually they very slowly grow to look more like almost a raised ring around the outside, more flat in the center. There can be scaling there. Some of them are itchy. They usually have been there for a long time. It's unusual to say, oh, it just showed up overnight. And those also require the topical fungal creams that you can get over the counter. But also take 4 to 6 weeks, and usually within a week to 10 days of starting treatment, you can tell it's making a difference in how they look. You have to make sure you don't quit then. You need to keep going for an extended period to be sure that you get it cleared up all the way.
Okay. As far as the topical products, then, which ones would you recommend?
Clotrimazole, which is generic for products like Lotrimin, works very well. Used to use Tinactin a lot on athlete's foot. I think there's a little bit of resistance to that, but a person who's never had to use an antifungal would be fine with that.
Okay.
Lamisil is a newer one. It's a little more expensive. I try to save that for cases that seem a little more resistant.
Okay.
And sometimes we have to use a prescription strength cream.
Good. Okay. Any other rashes that you want to discuss then?
You know, I guess the only thing that still falls into that fungal category and are guys that have to wear gear to protect their genitals in hot, sweaty weather can get what they call Jock Itch.
Okay.
And that's sort of like it's in the ringworm family, but hard to treat because it's hard to keep that area dry.
Okay.
But again, very, you know, making sure that you get out of your sports gear and get that area dry and that you're using powders or creams to treat it are important because it can make you pretty miserable.
Okay. Well, thank you very much then.
You're welcome.
Well, thank you, Dr. Bleicher, and we'll see you next time on Talks with Docs.